next we have Dr. Shruthi Desai, the next case. Dr. Shruthi has done her MRCP and she is a fellow student at ChanRe.
Good afternoon everyone. Today I'm going to be talking about two cases who came in with different presentations with a single pathology. So my first case is, we had this 34 years old woman who is a mother of 7 years old child who was referred to ChanRe center in view of recurrent breast abscesses. So her history goes like this. So up until 2018 she was doing okay, and then she developed some dry scaly lesions on the palms and soles. She was diagnosed with palmoplantar psoriasis by a dermatologist, was started on methotrexate, which she continued for 2 years. Then she improved and the medicines were stopped. She was okay for until end of November 2020. Then she had an episode where she developed fever, severe headache and neck stiffness. After a lot of investigation, she was diagnosed to have viral or aseptic meningitis, which was treated with conservative management with IV antibiotics and anti-edema measures. But what was unusual about this episode was that for almost 4 to 6 weeks she had a persistent headache and a prolonged papilloedema, which was confirmed. And again it was thought to be secondary to the resolving meningitis, and again some symptomatic treatment were given to her. So you can see the array of investigations that were done at that time. So the MRI brain scan was normal. The CSF analysis had shown cell count of 120 with predominant lymphocytosis of 90%, neutrophils 10% and sugar and protein being normal. No much rise in the inflammatory markers. Culture and sensitivity had shown no growth. And the TB test including TB PCR and 1-2 tests were negative. The India Inc. test were negative for cryptococcus. And because of the prolonged papilloedema, she had a repeat CSF analysis which again showed a predominant lymphocytosis. So at this point she had a autoimmune workup done. So where ANA profile, ANCA were negative, serum A's were normal, and HLA-B27 was done as well, that was negative. Then she improved symptomatically, and then towards the end of next year she started developing pain and swelling in her breasts. Through the ultrasound she was confirmed to have right breast abscess, which was quite large, so 8 by 10 centimeter, with few axillary lymph nodes. So this was drained, given few courses of antibiotics, the abscess resolved, and again few months later she had a recurrence of abscess in the same breast. So these were the investigation from her abscess. So during the first abscess, her histopathology had shown dense mixed inflammatory cell infiltrate into the fibroconnective tissue with microabscesses formation. Again you can see there was mild leukocytosis, ESR of 45, culture and sensitivity was negative, and the TB tests were negative. So this resolved with antibiotics, and then during the second abscess which was drained, the histopathology this time confirmed non-caseating granulomatous inflammation, which comprised of histiocytes, epithelioid cells and some foreign body giant cells, but no malignant cells, and again TB tests were negative. So with this histopathology she was referred to ChanRe. So when we assessed her, essentially she had no other features except for those breast abscess and the breast lesions. She denied any constitutional features in terms of fever spikes, weight loss or loss of appetite. She had no other features of connective tissue diseases, no other cardio or respiratory symptoms, and no changes in the bowel and bladder habits. She was a mother of 1 child with no bad obstetric history, and examination was predominantly normal. The investigation what we had done had shown a mild leukocytosis, mild rise in CRP of 14, normal albumin, normal globulin levels, TB quantiferon was negative, AS levels were normal, ANA was negative, and we got immunoglobulin level because of the recurrent abscesses, and again they were also within the normal range. We got IgG4 level which was normal, serum calcium was 9.4 and thyroid function tests were normal. So considering all these features, so she presented with non-caseating granulomatous lesion, she had no constitutional features, and all the other infective workers and particularly TB test was negative. So with this we put her as a diagnosis of sarcoidosis. So we commenced her on HCQ, methotrexate and steroids, but the story doesn't end here. Few months later she was admitted in our center with fever, productive cough and fatigue. HRCT test confirmed multiple pulmonary nodules. Again all the TB workup was done which was negative. She was treated with 2 weeks of antibiotics, augmentin and claribut, but she did not improve, the cough worsened, and when her cough improved, when we escalated her steroids. So we felt again this was a flare of sarcoid, so we switched her methotrexate to MMF. So she did improve from chest symptoms, but again after 2 months she developed new cutaneous lesions on the left breast, new papillonodular skin lesions on the abdomen, the what you can see there. Ultrasound breast this time again confirmed multiple subcutaneous breast abscesses, but they were very superficial abscesses with no deep extension and no axillary lymphadenopathy. CRP was 55, ESR 75, and total count of 11,000. She was given a week of antibiotics. The lesions started to worsen, and again we felt that this could be again refractory sarcoid with recurrent flares. So due to the refractoriness of the disease, we decided to give her infliximab. So she received 200 milligram of infliximab, 3 doses. After the first dose of infliximab, she started showing improvement actually. So she responded to infliximab, her breast lesions and the skin lesions disappeared. So after the 3 lesions, we kept her on a maintenance dose of methotrexate, prednisolone and HCQ. So if you look at the whole her clinical course from 2018, when she presented with palmoplantar psoriasis, whether this could be a start of her autoimmune process, and then later on she developed this viral or aseptic meningitis, which was not a usual pattern what we can see in viral meningitis. She was not sick enough for viral meningitis, but she had this prolonged protracted course, which resolved on its own without any steroids. Then she had this recurrent breast abscesses, then pulmonary nodules, and then recurrent of the skin lesions, with requiring various treatment at different point of time. So this was our first case. Then second case was, we had a 64 years old woman who was a asymptomatic patient, but she was referred to us with an incidental detection of ureteric stricture and hydronephrosis. So again her course goes like this. So 2015 she had a biopsy proven sarcoidosis. So when she presented with 3 months history of cough and intermittent fever spikes, her HRCT chest had shown pulmonary nodules, TB tests were negative, lavage was non-conclusive, serum AS levels were normal, but her serum calcium was 12.2. So with this the lung biopsy had confirmed presence of granulomas with no caseation and presence of multinucleated giant cells. So at this point she was treated with steroids, she made symptomatic treatment, and then she was lost to follow-up. She remained asymptomatic but developed nephrolithiasis in 2016 with mild hydronephrosis and mild rise in creatinine levels. At this time she went DJ stenting and then again remained asymptomatic. In 2012 she underwent a routine health screening and she was detected to have this ureteric stricture on a routine screening, which was again later on confirmed with a CT-KUB. CT-KUB had shown a shrunken left kidney, so the kidney size was 6.6 by 2.3. She had a moderate hydroureter nephrosis. She had a stricture in the proximal ureter with involving quite a length of the ureter actually. So it was 5.5 centimeters. So the quite large length of the ureter was involved. So she undergoes a ureteric stricture stenting, and the biopsy of this showed a granulomatous changes with giant cells. So with this biopsy report she presented to us. So we did a re-examination of her ureteric biopsy, which showed again a lot of moderately dense inflammatory infiltrate consisting of lymphocytes, histiocytes and plasma cells, and also the fibrocollagenous tissue had foci of calcifications and lymphocytes and histiocytes and presence of granulomata with multinucleated giant cells. Her other history included hypertension, diabetic and hypothyroidism, and again examination was unremarkable. These were the other investigations. Again very mild elevation in CRP of 24, ESR 35, normal globulins and normal albumin. You can note the creatinine slightly raised at 1.46 but normal electrolytes. The immunological workup we had done, so the ANA was negative, ANCA was 1+ atypical, but ANCA profile was negative, but this ANCA positive did not correlate with the biopsy finding what we have. ACE levels were normal and IgG4 levels were also normal. So serum calcium levels were normal and slightly elevated PTH with low vitamin D, and TB quantiferon tests were negative again. So again with her, so we needed to correlate the reason for her granulomatous ureteric stricture. So she had a confirmed diagnosis of sarcoid in the past, then developed nephrolithiasis, probably secondary to hypercalcemia, probably secondary to sarcoid, and now granulomatous ureteric stricture. Again she remained asymptomatic, no constitutional features. So with all this, so we put a conclusive, inferred as probably the sarcoid causing the ureteric stricture and hydronephrosis and the shrunken kidney. So she was commenced on methotrexate, HCQ and Visulin. With that we can see that there is an improvement in the inflammatory markers, although the creatinine remains stable and no worsening of the renal functions. So both the cases were unusual in that in the first case they were the granulomatous mastocytitis, and the second cases were the ureteric stricture. So we looked at certain case reports, and there are case reports involving both these organs. So this is the one other case report involving the sarcod of the breast. So this case report is showing that there can be a ureteric sarcoidosis. So with both the cases what we inferred was, especially in country like ours where we do come across the granulomatous lesions, and when the tuberculosis is always a differential for us, we should always be aware that the sarcoid can have a chronic indolent course, they can have unusual organ involvement, and they can present with various different presentation at different space of time. So putting all of their past history and all their clinical findings together can help us in the diagnosis and their management. Thank you.
Yeah.